Pretty awesome. Okay, good evening, everyone. Sorry to include into your dinner conversations. Welcome. Good evening again, and here to welcome all of you on behalf of the Center for Business GIS and Spatial Analysis in the School of Business and the University of Redlands. My name is Abhijit Sarkar. I'm faculty member of the school and presently director of the center. Just a little word about the center itself. It was founded in the School of Business at the university in summer of 2011. And it seeks to stimulate, support, and integrate spatial thinking throughout the curriculum and expand research and scholarship in GIS and spatial analysis. Before I introduce our speaker today, I would like to welcome again several students who are here, students who are probably taking time off from class, students who are interning here over the summer, visiting from our partner institute in India. I'd like to welcome faculty colleagues, administrators, guests, other members of the university community, and the community at large. I would particularly like to welcome faculty colleagues from Claremont Graduate University, from the Center for Information Systems and Technology, and several students from the Health Informatics class that's been taught somewhere at CTU. So welcome to all of you as well. And without meaning to take up too much more time, I'd like to acknowledge really meticulous behind-the-scenes preparations of two really outstanding individuals. Vanessa Celia Zorro is seated right up here. She does what she does in a very capable fashion. I don't know how she does it, but she does it. And Jessica Rosales is a current School of Business student in the MBA program. And a graduate assistant for the Center for Business GIS and Spatial Analysis. I'd like to thank them both. Thank you both for that. So without further ado, it's my pleasure to introduce our speaker today, Dr. Geraghty. Dr. Geraghty is Deputy Director of the Center for Health Statistics and Informatics with the California Department of Public Health, where she leads state vital reports and public health informatics programs. In this role, she has been focusing her energy on statewide initiatives in meaningful use, health information exchange, and data interoperability. Dr. Geraghty also maintains her affiliation as a clinician researcher in the Division of General Medicine at UC Davis. Her research focuses on using GIS to influence health policy and advance community development programs. As you might expect, she has authored research in pesticide exposure modeling, statewide mental health service access and use of tracking systems, asset and disparity mapping of youth outcomes, and index development for youth well-being and vulnerability. For the past few years, Dr. Geraghty has been thinking and talking about geomedicine, and she's been traveling extensively both nationally and internationally to talk about this particular topic, which is what she's going to be talking about today. Dr. Geraghty is a recipient of a prestigious University of California Award for Innovation in Information Technology as a part of a team that developed an electronic medical record data discovery solution. In addition to degrees in medical informatics and public health, Dr. Geraghty is a certified public health professional and perhaps esoteric and geographic information systems professional as well. So with that, it's my pleasure again to introduce Dr. Geraghty.
A kind introduction, thank you. And I have to say, I'm just so happy to be here. Very thrilled to have been invited. I really appreciate that. To share with you something that I think may be new to you. Thinking about how can we use geographic information at the point of personal care, when a patient sees their clinician. But to get there, we're going to go through an entire story, and maybe at the end you'll also kind of see how my two worlds are connected, and I think GIS kind of brings it all together. So the way I'm going to do it is I'm going to talk about how we got to this place in time where geomedicine could be a reality, And so it won't be a full history. I give you a selective history based on what I think is interesting. And then I'm going to define geomedicine and tell you about it from a number of different perspectives. How different patients versus clinicians, health systems might be thinking about this. And sort of integrated with this, I'll be talking about challenges as they come up. Certainly technology challenges, as well as culture change. You know, that's always a difficult one. It's way harder than technology. And then training, you know, how do we get a workforce ready to do this? So that's the plan. Now, it didn't surprise me that the first time I had heard about health and place was with Hippocrates. And so you can see that this was around 460 BC, and he had some writings on airs, waters, and places. And so I wanted to share with you what he said. So he said, when a race lives in a rough, mountainous country at high elevation and well-watered, where great differences of climate accompany the various seasons, there the people will be of large physique, well accustomed to hardihood and bravery, with no small degree of fierceness and wildness in their character. Okay? Now, on the other hand, he said, in low-lying, stifling lands, full of meadows, getting a larger share of warm than cold winds, and where the water is warm, the people will be neither large nor slight, but rather broad in build and fleshy. Bravery and hardihood are not a natural or integral part of their characters. And so as we begin this, I want to point out to where I live and ask you to please be gentle with me because I do belong with the cowardly and the meek. But I bet that you hadn't heard the story about the great physician Geraghty, who was a fabulous spatial thinker. Now, he was truly a Renaissance man. He wrote encyclopedias on all sorts of topics, not just medicine, but he thought about many different things. What made him unique in medicine is that he approached disease based on observation rather than on spiritualism. Now, he was alive during the Middle Ages, so this is quite unique. But he was a great spatial thinker, and that's what I want to tell you about. He got tasked with finding the location to build the next hospital in Baghdad. And so what he did is he walked around the city and he hung slabs of beef in the corners of the city. And he continued to monitor those slabs of beef to find out which one putrefied the slowest. Because in that location, he figured the air must be cleaner and everything must be healthy in that location, so that's the best place to build a hospital. So that's great spatial thinking. And then this has been noted as the first map that is health-related from 1694. Now this comes from a man named Filippo Arietta, who was an assistant to the royal governor in his area or province of Bari, which is near Naples in Italy. And this map is focusing on plague. And what you can see in the map, and I'll help you to see it more clearly, is that although they didn't know what caused plague at the time, they did know that it could sometimes be contained. So this map is all about containment and quarantine. So the first level of containment is on the shoreline, and you can see that they've got these boats protecting the shore, not letting anybody come into the affected area. Then they've got a second level of quarantine around that area, and the little dots that you're seeing are actually meant to symbolize military tents. So there was a very strong military presence here. And then they knew that they needed to restrict travel a little more broadly, so they have a third area of quarantine around the entire province. And so you also see the little tents there spaced out a little bit more. Within the province, the other things that you can make out is any of the buildings representing their hospitals or churches if they have a cross on them. And then the trees are unpopulated areas. But this is officially the first known health map. And then if you go forward about 150 years, you get to France. And in France, they started to have the ability or the thinking to do choropleth mapping. And so André Michel Geraghty started to create comparative choropleth maps. So he looked at this idea of moral statistics, looking at crimes against persons, crimes against property, and education levels. And he also did do this health map looking at suicides in France. And then there is, not too many years later, Du Châtelet's prostitution map is in Paris. And actually where you see dark colors is near where the Moulin Rouge is. So it's not surprising this habit continued. But what I think is interesting, and I just show you this for fun, is there's the Moulin Rouge. A different kind of mapping was done by Doug McCune in San Francisco area, and he used elevation to indicate prostitution in the San Francisco area. And so this is down Market Street, and the second, I'll show you a little bit better, is in the Tenderloin district, so he's naming this Mount Loin, appropriately so. And he notes, with his technique, how prostitution is casting a shadow over the majority of the city. So a clever way of sending a message. But that was just for fun. Now this next story, I'm guessing you may have heard of if you know something about health and mapping, but I'm going to start it in maybe a little bit different way. In London, they had just finished their second epidemic of cholera, and after that, 54 of London's poorest citizens sent a note to the London Times. And in that note, they wrote, "We live in muck and filth. We ain't got no privies, no dustbins, no drains, not water supplies, and no drain or sewer in the whole place. We all of us suffer, and numbers are ill. And if the cholera comes, Lord help us." Unfortunately, it was just a few years later that the cholera did come, and people were terrified because one person could wake up in good health, and within 12 hours they'd be dead. They would suffer from abdominal cramps and a racking thirst and this terrible watery diarrhea. And in this one location, within 250 yards of the intersection of Cambridge and Broad Streets, more than 500 people died in little more than a week. So think about that in a neighborhood. That's a lot of friends and neighbors. And so in comes Dr. John Snow, since named the father of modern epidemiology. He's going to be our hero for this story. And he created the most famous of all health maps, which is this map. And what you're seeing is the Soho district in London in the early 1850s. And all of the dark bars that you're seeing are deaths from cholera in a household. But what you can't see, and I'll help you, is that he also mapped water pumps in the area. He had a number of theories and went through them, but one of his theories was that maybe cholera happened in the water, because again, nobody knew what caused it. And you can see that there's an awful lot of death from cholera out around this one water pump. And so he talked to the, they didn't have a public health department, but he talked to officials at the time. They took the handle off of the water pump, and it ended the cholera epidemic that year. So he is certainly a hero of spatial thinking. And if you ever get to London, you can celebrate Dr. Snow at the John Snow Pub, which is very near that intersection at Lexington and Broadwick Streets. So don't forget to stop by. So this next story is about one of the greatest public health achievements of the last 100 years. So I would have to ask you, what would you rather have? Mottled teeth or dental caries? So you may guess, this is a story of community fluoridated drinking water. And fluoride, of course, is an odorless and colorless mineral. It occurs naturally in the earth, but at different levels. And the good news is it makes your teeth very strong. The bad news is, in excess, it can cause a brown stain on this modeling. So I'm going to tell you this story about Dr. Frederick McKay, who was a young dentist at the time in 1910, and he saw that a lot of his kids in Colorado were suffering from this brown stain in their teeth. They also noticed that they seemed to have some resistance to tooth decay. So he brought in this dental researcher, Dr. G.B. Black, and together they sort of worked on this issue and actually together made that correlation. But unfortunately, Dr. Black died in 1915, so Dr. McKay had to move on with this research on his own. But in 1923, he had a stroke of good luck. He had been invited to a community in Oakley, Idaho, where the kids were just having real severe brown stains on their teeth. And so he was asked to come out and examine the area, and he noted that that community had a brand new pipeline that was supplying their water. Again, he didn't know that it was fluoride that was causing this, but he saw the new pipeline and he told the parents, why don't you get your water from the nearby well instead? And so when the kids got their permanent teeth, they were fine. And so then they could start to make the relationship of fluoride in the water. So he had to start thinking about, well, how much fluoride? Because some seems to be good for preventing cavities, but too much is not so good. So laboratory testing started to happen, and this is when he brought in Dr. H. Trenley Dean of the U.S. Public Health Service, and they worked together on this dose question. And they finally came up with an answer in 1950. They were able to say that 1 part per million of fluoride was the best dose to prevent cavities and not get the brown stain. And that's actually what's recommended today still. So in just 5 years of that recommendation, in communities that had fluoridated drinking water, the prevalence of tooth decay decreased by 45 to 94%. And this is why it's one of the greatest public health interventions of the last 100 years. But people ask, well, you know, you're putting fluoride in the water. Is this safe? Is it ethical? It's like putting a medicine in my drinking water. So a lot of people are upset about this, and there actually was one research study that indicated it could cause bone cancer. That research is debunked, even by the author, who found errors in their work. But the opposition remains significant in some areas, and I'll have to say, you know, in California, right around where I live in the north, San Jose is the largest unfluoridated city in actually the country. So then I found this map. And this comes from Covert Action Quarterly. It's not something I subscribe to, but I love the title, Fluoride, Commie Plot or Capitalist Ploy. And what they're showing here is the percent of the public that is receiving community fluoridated water in 1992. And you can see California is number 48. So I know we think that we're always the pioneers in leading the charge, but in this case, we're well behind. But in talking about this whole idea of fluoride and dental health and geomedicine and how can we use geography at the point of care, I was talking to Eric, Dr. Fernandez Y. Garcia, who's one of my colleagues, and he's a pediatrician at UC Davis. And he said, oh, geomedicine, I do that all the time. I'm like, what? I had no idea. And he knows nothing about GIS, but he showed this. This map that he uses, that came from First Five, California. It's a paper map, and he said this map has fluoride levels on it. So areas that are blue or tan are fluoridated, and areas that are white or orange are not. And so when a patient comes in, he maps their address, and if they need a prescription for fluoride, he writes it. So he does geomedicine every day in clinic, just very low-tech geomedicine. So let's get to what is the definition of geomedicine. Now, Dorland's Medical Dictionary does define it, and they say that it's the branch of medicine dealing with the influence of climatic and environmental conditions on health. So that's okay. I think that this has broad implications for population and public health, but I didn't think that their definition went far enough, so maybe someday somebody will credit me with writing my own. So my interpretation of this definition is that geomedicine is really the branch of medicine in which the body of knowledge about how the environmental conditions, environmental being interpreted broadly, influencing health can be leveraged then to improve personal health. How can we make ourselves healthier by understanding our geographic exposures? So I thought that this was a much more translational way to consider the definition. It's meant to link GIS research with clinical care to get better outcomes. And it goes to what we already know, that our health is composed of our genetic makeup, our behaviors, and then that elusive big thing called the environment. So in clinical health, one of the early adopters of this idea of thinking about geography in clinical health was Jack Wenberg. And he was the one who initiated the Dartmouth Atlas Project as the principal investigator. And he said it's not just air, water, or infections. Actually, the density of medical practitioners of different types makes a difference in an individual's access to healthcare and some services, the likelihood of even getting a correct diagnosis or having a chance for a successful outcome based on treatment options available at different places. Or it's even related to your ability to receive affordable and timely care. And I had the chance to meet Dr. Wenberg at the Esri UC last year when he was promoting his brand new book, Tracking Medicine. So if you're interested in the topic, that would be an excellent reading choice. But let's talk about geomedicine now from a couple of different perspectives so you get a sense of what it might really mean to the different stakeholders in this area. So from the patient perspective, I mean, you know, if you're a patient, what do you want to know? How can you take advantage of geographic knowledge? Well, I think a lot of what you as a patient would want to know is, what are the resources around me that can help improve my health? Now, there was this app that won an award that started to do that in a small way. It wasn't based on just healthcare, but they were saying, okay, if we know your position, these are the important things around you: banks, gas stations, hospital, pharmacy. Now it seems we all have this available. But they did win a prize for their application. And of course, you can just put into Google, in this case I put weight loss clinics around me, and you get a list of answers. I would argue that this is not exactly geomedicine, because these answers aren't vetted in any way. You know, we want a clinical body, you know, some knowledgeable professional to say, these are the good clinics, and these are, you know, ones that maybe you don't want to go to. And then there's a little more relevant and newer application called iTriage, which tries to do an awful lot in this particular app. It's got symptom dictionaries, I guess, where you can look up your symptom and find out, what might I have because, I've got a pain in my lower left abdomen or something like that. So you can start to self-diagnose, but then say you get to the point where you really need to find a provider. In this case, I looked down the list of types of providers from hospitals and urgent cares down to what I selected was community health centers. And then you get a list of community health centers near, your IP address or your cell phone. And then I can choose one, and then I get the effort, which is a federally qualified health center in my area, and I can get a map and directions. I got the phone number. I can call and make an appointment. So this is what iTriage is trying to do to help consumers get their way to healthcare more easily. But they're also trying to do a little bit more of a mapping component. And this is a beta version, so it's not really showing any data yet, but it's just a reminder to me to let you know that they want to do something that is like crowdsourcing symptoms, not too unlike what Google Flu Trends does. Although that's just searching on things related to flu. In this case, it's patients who would put in, I'm having this symptom. You might have the model where people are just scanning symptoms and sort of seeing what the relationships are. But you could potentially get maps of what's going on in different places. So they're working on that part of the app. So that's a little bit of the patient perspective. This next example is a patient and clinician perspective, how they might work together. And this is one of my favorite examples. I really like it. And I borrowed the slides from my colleague at UC San Diego, Dr. James Killeen, who's an emergency room physician and has been working on this through a grant-funded study. And so in this, he's got a non-electronic medical record solution, so it's a standalone product. That's a downside, but a lot of those are being created. And it's a patient portal, so he can communicate with the patient through this, this application. And so you go into the application, a patient's got a profile. This is Gloria Gilliam, who's a 24-year-old woman, and she's got eczema and asthma and takes 2 medications for her asthma. And so then Gloria is equipped with a cell phone and this little doodad here. So if you haven't seen this before, this is something made by Propeller Health, and it's a GPS sensor. It fits right on the asthma inhaler. And so every time you use your inhaler and you hit that sensor, it records a date, time, and location stamp that can then be sent directly to your cell phone and mapping product. So now you can see maybe where your triggers are. Where are you using your inhaler most? But he took it a step further. So this is what it would look like in terms of the map. Over 6 months usage, 1 a week at a glance, we see that the asthma inhaler use is potentially appropriate, although you can see the areas right here where you might have a slightly hot spot. But based on the calculations, this is still good control of asthma. So then he takes it to another level using this product from CitySense. And this is a personal pollution monitor. It's a little bit boxy at the moment. They haven't made it active yet. But it does record 3 different pollutants. It has ozone, carbon monoxide, and nitrogen dioxide. And again, this is a little port that hooks into your cell phone, and you can get air quality readings directly from this device that you can wear on your backpack or your belt or whatever. It's bulky, but it's lightweight. So then you get something like this breadcrumb trail showing the levels of pollutants for all of the places that you went. In this case, this pop-up shows that there was a little bit more carbon monoxide than nitrogen dioxide or ozone. So you can imagine now, having all of this data, you might start to make some connections. So the application will record all of this for you in something that looks a little bit like this. And so if I blow it up, what you get is your air quality sensor measurements. The 3 different colored lines are, red is the carbon monoxide, and purple is the ozone, and nitrogen dioxide is in green. And then you also get your metered dose triggers from your inhaler. And so you can start to make connections. That first trigger could have been from carbon monoxide. And then when you look at the next 2, there's slight little bumps in the ozone, and maybe those were the trigger for those inhaler doses. So then the patient can say, okay, I'm putting all this information together and just sending it as a package to my provider. And so she sends it, she gets a return message saying, yep, got your message. And then the provider can open it and look at the results and say, okay, this is not well-controlled asthma. So now he sends a message back to the patient saying, you should increase the frequency of your inhaler to 2 puffs 4 times a day, and I'll see you in clinic next week. So then think about taking this to another level. So I think this is a good example of true geomedicine from a patient and clinician perspective. Both are participating and interpreting the information and making decisions on that. But then what if you take, for instance, the CitySense pollution monitor and contribute everybody's data, everyone who's using it? You could get some really nice maps that way. And this is exactly what is happening in Louisville, Kentucky, which does have a beautiful skyline, but they actually have one of the worst pollution problems in the country. And because of that, they have very high rates of emergency room and hospital use for asthma exacerbations. So in 2012, they applied for and received an IEM Smarter Cities Initiative grant. And with that grant, they wanted to identify their community-wide asthma triggers that could be improved or eliminated. They didn't want to focus on the things that they can't fix. But they're using that Propeller Health sensor, they're using CitySense, and doing all sorts of other GIS analyses, looking at school absences and work absences to try and figure out what is going on in their city. And they have 2 papers related to this. They're both in press, they're embargoed. And so I can't tell you the results because I don't have them. I've only been told that they're impressive. So we all have to be on the lookout for that to see if it's real. So the question that we have to ask ourselves is how can we take advantage of this great kind of population data that we've been working on in public health to inform our personal health? So thinking about the clinician's perspective individually, a clinician's pretty good at asking who, what, when, and why questions, but we're not so good at asking where questions of our patients unless they're saying, I just got back from an exotic trip, or unless they're planning to go on a trip and then we send them to a travel clinic. So the reason is that it's complex and hard to ask these questions in a very short clinical visit. And you don't want to just ask, where do you live, but you want to know where have you lived in the past, where do you work, where do you travel, how do you spend your time? And if you do it right, it can get pretty complicated. And this is the result of somebody at Esri who tracked their time for an entire year. And so doing it right is hard. So what do we need? How can we capture this kind of information? We certainly have important informatics needs. Electronic medical records first have to be able to store the information. Right now, you put in one address for billing purposes, it's not standardized or geocoded. So how can we not only improve that process, but then have this repository with previous addresses and amount of time spent at work or at home? So one way to potentially this is to empower patients in waiting rooms instead of sitting around reading the latest magazines that nobody's interested in. They could potentially work on a kiosk and start loading their previous addresses, even if it's just remembering a city or county they lived in. So that might be one solution. But of course there's an app for that, or in this case there was an app for that. It's not available anymore, but the point of this slide is the technology is there. So Google had Google Latitude location history component, and it was private, so you could make sure that you didn't share your location address with anybody else. And you could do things like at the end of a week, say, okay, I worked 30 hours, or I was 30 hours at work, 51 hours at home, and 48 hours spent in other places. And that might be good enough to put in your record. Maybe, though, if you are an asthmatic, you want the temporal breakdown of exactly where you were at what time. So it is possible to collect that. And we'll tell you that it's actually possible to get it into an EMR. And I draw on this technology as evidence because I think it's somewhat similar. So glucose levels for diabetics, they're taking their blood sugar up to 4 times a day. And so it's got that temporal component and needs to be recorded in electronic medical record. So in this case, it's a wireless glucose monitor. This particular example is 3G sent over a cell phone to a data warehouse that a clinician can then access and make decisions on. So again, my point is the technology is there. We just have to make it work for a different purpose. So then you get all of this information. What do you do with it? Well, another informatics need is decision support tools, right? So that you can put together a patient's place history where they've been, lived and worked, with their medical history, which is going to tell you something about their susceptibility to disease. And then you've got all these place-keyed exposure. So I know that, in Scranton, Pennsylvania, there's exposure methane gas. And what does that exposure then mean in terms of risk of particular diseases? And then you put it all together so that the clinician now, without having to do anything else, can say, oh, for this individual, I may have to screen 5 years earlier for colon cancer, or do something different when they have symptoms, because I have a little bit of an early warning sign here. So for my friend at Esri, when you take his place history and break it down, this is what it looks like. And ultimately, the way he calculated it, he spent 67% of his years in compromised environments, and 70% of his hours were spent within his community in those environments. So according to his research, his geographically relevant or place history leads to an increased risk for cardiovascular, pulmonary, and central nervous system health issues. And in fact, he did suffer a heart attack, which is part of what made him think about this. He's fine, but it got him interested in the topic. You know, why did my physician never ask me what my exposures were, if my exposures all lead to an increased risk for cardiovascular disease? How could I have done things differently if I had had that information or if my clinician had that information? So now let me move on to a sort of a broader perspective, how might the health system think about geomedicine? And certainly healthcare reform has had a big driving force in making us consider upstream effects of medicine. And so I point to this book. This is one of my friends, Rishi Mananda, who wrote this book called Upstream Doctors. It is available on Amazon for 99 cents. I have no financial interest whatsoever. It's just a good read. But he, in the beginning of his book, he tells a story that I really like. And the story goes something like this. 3 friends come upon this beautiful river, and they're standing at the side of the river, just watching it, and all of a sudden, a young child is screaming and paddling and trying to keep its head above water coming down the river. And this is a problem because at the end of the river, there's this great huge waterfall. And so the friends jump in and pull the child out. Well, as soon as they get the child out, they see another child coming down. And this continues time after time. The kids start to come faster, and the current starts to move faster, and they're getting exhausted. They're starting to do this all day long, and don't know what to do or how to stop the problem. And so after some time, they can't give up because they're being pretty successful saving most of the kids, but they just don't know what to do. And then one of them just takes off and starts swimming upstream. And so this is that swimmer. And the others are astounded, and they stop and they yell at this person and say, "What are you doing? Why are you swimming away?" And this one person says, "I'm swimming upstream to find out who's throwing the kids in the water." So getting to the root cause of the problem, right? You need to go upstream to figure out what are those factors that are causing the problem. And this is often referred to as the social determinants of health. And I just use this diagram to point out that the upstream factors include these important things like class, race, ethnicity, gender, immigration status, sexual orientation, among other things. So we need to think about those things. And Rishi Manchanda has been doing that in his clinic in a way that I think is an effective use of geomedicine. So he tells people, and I agree, that if you want to make a difference in improving health on the individual level, it is not in medical care. That, I mean, yes, obviously that's important, but that's only 10% of the impact on health. Family history and behaviors, of course, are the majority, but if you really want to make impact, you can go to social and environmental factors, and you can do quite a lot there. So this is where he's focusing a lot of his attention. And what he's done is he's got a clinic, a small community clinic in Los Angeles, and he's used GIS to map 54,000 patient records on what he's saying is housing-related illnesses that are associated with asthma in his population. And he hadn't realized this before he started actually questioning one patient who couldn't get better. No matter how much medicine he gave her, she continued to be sick. And when he did this, he saw clusters of asthma that he had never seen before. And so he cross-referenced this information with local housing enforcement code records, which he does note are sometimes hard to get. But you can find out where, not only from the census, where houses may be older, but where there are code violations, because that tends to be where people are getting sick. So he did that, and then he took that, in order to start to get that information on a more regular basis, he developed a new intake form for patients that they could fill out in the waiting room. And it asked questions about housing and schools, where people were going, what kinds of neighborhoods they lived in. And he started to link patients with community services that were available. And so then how did he get those community resources? He crowdsourced them. He asked people what are their favorite parks, walking trails, and exercise programs. Where are the great farmers markets in the area? Where are there lawyers who are open to doing pro bono work that can help address these housing code issues? And where are there dynamic teachers who are interested in health issues who can start to tell people that there is a correlation between where you live and your health? And then they can start to work on these interventions. So he's been doing all of this, and I just think that it's really brilliant use of geomedicine. So I highly recommend his 9-minute handbook. But there is the public health perspective. And so I would say that epidemiologists absolutely need to continue to do their great work, continuing this research on the environmental factors that correlate with risk of health problems. And we need to know things like how long do you have to be exposed to something and how much exposure do you need before you get sick, right? Otherwise, we can't do the decision support tools down the road. What are the interactions of multiple exposures? I mean, it's hard enough to figure out if you're exposed to methane gas, but maybe you're also exposed to some other pollutant, and maybe they interact in some way that, catalyzes your risk of disease. And how do exposures relate to individual biological susceptibility? An exposure for a young, healthy person might be quite different, of course, than an exposure for a very young person who maybe has an underdeveloped immune system, or an older person who maybe has some illness and an immune system that's not working as well. We need to consider large geographies like the entire US at local scales so that we can get things done. Because we all know, preaching to the crowd, that variation happens locally. And they need to consider making data and maps available online so that they can be consumed. I'm sure you guys have heard, there's all sorts of developer challenges, codeathons, hackathons, data paloozas, where people are getting money to create these apps to match up different health data sets and come up with solutions. And of course, I can't mention any of this without saying that this is health data we're talking about. We always have to be cognizant of the privacy issues and do it right. It can be done, it just needs to be done. And so I wanted that to lead into a brief discussion of some of the things that are going on in health informatics, public health, and data in general. And one of them is open data. So that suggestion that epidemiologists need to make their data available and consumable is happening. And good news, I'm leading the charge in California, and we're going to have an open data portal for our data sets starting in August. So I'm working really hard on getting data sets ready, and expect about 5 or 6 data sets to start, and we'll add to it and add other agencies after public health. So healthcare services with cost data, statewide planning and development with emergency room and hospital discharge data, social services with foster care and other child relevant data. So it's all going to be up there. And in fact, the rest of California government is interested in doing this too. So data sets like transportation and parks, etc. So open data, if you're not familiar with it, is really just about making data usable. It's data that can be freely used, reused, and redistributed by anyone, subject only at most to the requirement to attribute and share alike. So this is all government transparency. I see it mostly used in that venue. And one of my heroes is this gentleman, Dr. Nirav Shah, and I met him last July, and he was, until just 2 weeks ago, the health commissioner for the state of New York. And he developed his own level of fame by being one of the early adopters for open data. And so New York has quite an amazing website there. But when I met him, I was so inspired, and I told him, we're doing it. I was only 2 months into my job at the state and didn't know the bureaucracies I have to fight. But it worked, and we are doing it, and so I feel really good. So I have to tell you the story about how his open data portal did so well. So they started with just 6 data sets. And when they put them up, he tells the story that he put up one data set that he thought was the most boring data anybody could ever imagine, nursing home bed census. Who cares about nursing home bed census? So this is a map of the nursing homes in New York. And only a week or 2 after his portal launched, Hurricane Irene hit New York. And so telephone lines, were not the best way of communicating, but people could actually get online. And for people who were in harm's way of the hurricane in nursing homes, they found this website. They found, by clicking on one of the nursing homes, you could see whether or not the nursing home had a bed related to a ventilator bed or other things that patients would need. And so they were able to move many, many patients to safe areas during the hurricane. And this got so much media attention, very positive media attention, that the Governor Cuomo at times said, we're doing open data. And he created Executive Order 95 saying all of New York is doing open data, and that's it. So, it's a terrible disaster, but in terms of open data, it certainly worked well for pushing that through the state. California is going to be a little more grassroots. I don't want us to have any disaster when Governor has to say, let's go forward. So one place that I just wanted to let you know about, if you haven't heard of it, is the Health Data Palooza, which I think is a great place for innovation and hopefully innovation about geomedicine. So this is a conference that takes place at the federal level every year. It's in Washington, D.C. I'm actually going next weekend, so it's always in early June. And the point is that data mining, which, you know, if you're a researcher at all, you know, has always been kind of a dirty word. I will tell you now that data mining can be done in intelligent ways and doesn't have to be a dirty word anymore. And to give you a sense of what's happened in the last year, in 2012, or 2013 actually, data.gov, the open data portal for the federal government, had 75,000 data sets available. Over 60,000 of those were geospatial, by the way. So if you're looking for data, you have a choice. And in 1 year, there were, just like a month ago, 90,000 plus data sets. When we go to healthdata.gov, a year ago there were 411, now there are 1,540. When we get California on board, it's a skyrocket. So that's my personal promise to you. And Rob Shaw, for all his work in New York, won the first ever Health Data Liberator Award. So I just want you to get a sense of what the trend is, that there is a trend towards sharing and openness and putting data in the hands of people who can innovate and do something great with it. So again, from the public health perspective, there are a number of other things going on. Public health agencies are collecting clinical information now in different ways. So maybe in the future there's going to be less reliance on sampling through surveys, and we'll be able to get actual clinical data to make decisions. So potentially this will be more accurate as well. And we should also be able to then turn around and share those data with clinicians. So what do I mean by that? Well, in my last few slides, I want to tell you about what's going on in the world, if you haven't heard. In 2009, we had the American Recovery and Reinvestment Act. And that act was meant to invest billions of dollars into the American economy in particular sectors of the economy, of course, as a stimulus. One sector was health IT. And so from that was developed HITECH, which is an acronym for Health Information Technology for Economic and Clinical Health. Well, the purpose of HITECH was to incentivize hospitals and providers to start using electronic health records. Because the idea was that this is how we're going to get more value. We're going to, one, I have to say, be able to read people's thoughts, having been through non-electronic records. And data can be shared, right, from one provider to another much more easily. It might avoid duplication in lab tests when you move from one provider to another, or radiographic tests. So the thought was that when you have electronic health records, you're going to improve patient outcomes. Well, incentivizing people to adopt electronic health records is one thing, but how do you figure out that they actually did it and did it right? Well, something similar happened in Australia many years ago, where they were going to find $10,000 to clinicians who adopted an electronic health record. So a bunch of clinicians went out, paid $1,500 for a laptop, put a patient record on there, and claimed their $10,000. So they got an $8,500 profit and a new laptop. So the U.S. didn't want that to happen. So they created meaningful use. And meaningful use began, and has since grown, with a 555-page document saying exactly what you have to be able to do with your health record to get the incentive. But the incentive is somewhere around $65,000 per provider. So it's worthwhile. But the reason that this is relevant to public health especially is that in stage 2 of meaningful use, clinicians and hospitals have to share data with public health. And the data that they have to share are these ones that are listed. They share electronic data for immunizations. So now we can have a statewide immunization registry, which we've never had. We have now a registry for reportable lab results. So all of those communicable infectious diseases now get reported to the state. We can do syndromic surveillance. This one is an optional measure, and I have to say, please ask me if you want to know more, but syndromic surveillance is a little tricky, not easy to do, and I don't think it's well proven. It also has the option of reporting cancer cases for a cancer registry. And I have to tell you, California already has the best cancer registry in the country. But this will make it electronic, and data will come faster and populate that registry sooner. And then they have this section called Other Registries, which is ill-defined, and so we can make that up. And so if you have ideas for other registries that we should have in public health, let me know. But what's exciting about meaningful use and why it's relevant to geomedicine, I think, is that stage 3 is about bidirectional exchange. So let's take the immunization registry example. Now I have a statewide immunization registry, but it doesn't do anybody any good if you can't tap into that, right, and find out, okay, the child before me lived in Southern California and moved to Northern California, has already had 4 doctors. How do I know what their immunizations have been? I personally have been fully immunized 3 different times because my records got lost. So I'm well protected, you know, I'm supposed to be anything. But there's a lot of even suffering that went along with that. So, so this is a great way to collect a lot of data and start to use it in meaningful ways and give that environmental exposure information back to clinicians to use for personal health. So you can imagine that with all of this data exchange and collecting data, we are going to be struck with this tidal wave of big data. And so just briefly, you're probably aware of the 3 V's of big data. Some people say like 7 or 10 V's. You can come up with as many V's as you like, but the primary V's are the volume of data. And if you weren't aware, we collect now in 2 days the same amount of data that has been collected from the beginning of time to 2003. Every 2 days we collect that much. So the volume of data is immense, and we're quickly headed toward bytes of data. This is a storage issue as well as a retrieval issue, and then there is the velocity of data. So it's not only coming in very quickly, but we need to be able to analyze and return answers to data very quickly. Imagine the situation of credit card transactions and potential fraud, right? You can't be fast enough to prevent fraud. It's got to be immediate. And then there's the variety of data. We have so much now. It's not just, you know, a spreadsheet or database. It's video files, clipstream, log files, all sorts of audio files. All of this can be analyzed. So in the health arena, we think about things like genetic data, certainly big data, imaging data, electronic medical record data. What do we do with all of this? And then you've got the quantified self, right? In many ways, people are measuring their heart rates, their blood sugars, their blood pressure. And then you've got your outdoor environmental sensors. How do we capture all of that and put it together to make use so that we can improve personal health? And then, of course, maybe your doctor can even figure out from your retail data that you've had those Pillsbury crescent rolls and 2 packages of bacon. So there's a lot of data out there that can be consumed and used for our health. But processing big data is not a little issue. It requires hundreds to thousands of servers, and they need to work in parallel. So the computational infrastructure for this is going to be difficult for any one institution to maintain. So the solution really probably needs to be in the cloud to take advantage of dynamically allocating the computing resources over the internet. And so this is where Hadoop comes in. If you're not familiar with Hadoop, this is what Google uses and a number of big names that you would be familiar with. But it is a framework for processing big data, repackaging it in ways where it can be processed. But the reason that I bring this up here is because Hadoop tools are incorporated in Esri software. So if you are doing big geographic analysis, you can actually get answers back on data sets that have billions of records within 2 or 3 minutes. So pretty remarkable processing considering what we've been used to. And the reason that this is important is because we've got to make the data smaller. So this graphic is showing you facts per decision on this side, and this side over here is saying, okay, what facts are we talking about? In proteomics and genomics, you know, you just have so many facts to deal with, and how do you put them all together? But here's the interesting part, is over time, over all these years, our cognitive capacity to make decisions based on facts has not changed at all. So with this big data revolution, we've got to have analytics that will make it reasonable for our capable small minds to make wise decisions. And so just to finish up here, how are we going to do all of this? I mean, it's a lot to take in and a lot to think about. Well, healthcare providers need to have some training. They need to learn how to think spatially. There are certainly some that do. I do. But not everybody does. And so I think that training needs to start earlier, like in medical school, to get some of this context. You know, I talked to you about the history. Just understanding some of that history, I think, helps people to understand what spatial thinking can do. And I do think that some specific spatial skills development needs to occur. You know, maybe some basic interaction with the software would help. But then we also need analysts, and I think that's become clear in many ways. Scientists and computer scientists need to work together with epidemiologists, geographers, statisticians, and more. I mean, today I think you've probably all noticed we can't do anything anymore without team science. We have to work together because we have such small areas of specialization that it's really important that we pool our resources to get the job done. And so I ask, it's been said that genomics is the area of personalized medicine, based on the awareness that genetic variations can cause different patients to respond in different ways to the same medication. Okay, that's genome-based medicine. But I would argue that your unique exposure history has just as much to offer in healthcare and should be as well funded. If there's anybody who knows anyone from the NIH. And that is what geomedicine is about. So I think it's nature and nurture. And so let me summarize. I've told you in a nutshell, there's a long history of spatial correlations with health. Geomedicine proposes to bring geographic knowledge to the point of care, and policy and technology are, in fact, evolving to create what I would call a generational moment in healthcare. Things are changing in ways we maybe couldn't have imagined, but it's a pretty exciting time. And just to show you that I'm truly a GIS geek, I'm going to leave you with this picture, and would be happy to take any questions at this point. Yes?
Yeah, one of the issues about protected health information is when we try to do analysis, the de-identification that occurs includes, as an easy item, removing address. And so you get things at the county or state level, which makes geoanalysis impossible.
Yes.
Could you comment a bit about where there may be some inroads to providing a greater level of granularity to de-identify data?
Sure.
Because that seems to be a real kind of barrier.
Well, we start with the problem as you've articulated, there are, as far as I know, 3 levels of laws related to personal health information and sharing that. The first one is safe harbor, which is the international law, and there are 18 identifiers that have to be removed in order to be legal. Then there's HIPAA, which is the national law that we all adhere to, and I think that has slightly fewer identifiers, but very similar to safe harbor. And then California actually has the California Information Practices Act, which is even more strict. So certainly a big problem because we know that variation happens locally, and we want to capture that. We don't want to just end up with some regression to the mean. So I'll push that, I think, in 2 different ways. The first one that I find very interesting is, in a lot of our research, we're willing to take the personal address but aggregate our results. Right? We need to have the address, do the analysis, and then we can show the results in an aggregated fashion. Aggregated data doesn't seem to have as strict a rule as HIPAA and Safe Harbor, but needs to be done with care because in GIS, as you may have realized or read newspaper articles about, you can mosaic many layers and end up with identifiable data if you do it right. So hackers are challenged to do this all the time to ensure that a data set might be safe. But we are working with the Department of Healthcare Services and the Department of Public Health is trying to develop guidelines for how to do aggregation in a safe way. And we're looking at rules like a numerator rule. If you have this many observations in your numerator, you're safe. Same with a denominator rule. You can do a numerator and denominator rule. And then there's all sorts of other rules. So we've got sort of a decision tree model that we're building that we'll share openly with anybody. And hopefully that will make people and their lawyers feel safe, happy. So the other issue is, how do I get identifiable data, and then I can do responsible things with it? It's hard. Like I can tell you from my perspective, we give vital records data to researchers. Give us actually the wrong word. We charge researchers for vital records data, but it's nominal. And you have to go through the State Committee for the Protection of Human Subjects. And then you have to go through ESAC, which is our Vital Statistics Advisory Committee. So it's like a second IRB. So it is a lengthy process. But you can actually get individual observations with addresses. So I think when you want that level of data, your research plans have to include extra time because through these state bureaucracies is possible, but it's hard. And you have to show that you're responsible and you understand some of these aggregation issues. And then the last comment I'll make about it, because this is such an interesting topic to me, is for point data. If you are working with point data and an individual address, how do you move that in a way that masks the individual but doesn't mess up your research because you moved them into another socio-demographic category? I actually have a graduate student who's working on that, and hopefully will be successful, but it is a challenge. So you're asking all the right questions. I have all the answers, but I tell you we're working on it. Other questions? Yes?
How much resistance did you get when you started your open data initiative? I mean, this opens up the doors for whoever sits in the room to attack politicians in the heart of their vulnerability right from the get-go, especially those that have been pretty much around for a long time. You guys always say, oh, yeah, the old ones that did those bad regulations.
Yeah.
So you're opening up the doors of the floodgates to pretty much shoot politicians down left and right.
Well, there was a lot of resistance, and the resistance, I think, was, I could combat it through education, but it took a lot of time, and I answered a lot of questions. So there was one person who had to really give the go-ahead to then get to the next levels where I would get full approval. And in his job, he actually, anytime he ever heard the word data, it was associated with the word breach. And so his fear was immense on open data, and rightly so. I mean, this is his whole experience. And so he had a lot of questions about not only that, how do we protect the data? In the case of open data, that was really kind of an easy fix because we're talking about data that are already published in our website in PDFs and making it now accessible as a CSV, downloadable, filterable, visualizable, mappable product. And so we got over that hurdle. But then there were other questions like, what about public expectations? Once you do this, there will be an expectation that our data are high quality, that they're timely. We update it, on a regular refresh cycle, and we thought that was good. We want high public expectations because we want to be forced to meet those expectations. I mean, that's my perspective. I know we're not doing as well now as we could. I mean, we're in my center, we're just putting out 2013 data. No, 2012 data. Sorry, that's why it's so bad. And I'd be happy something public like this really would work to our benefit to deliver a better product. So we had to answer those questions about public expectations, and then we had to answer questions about what if people use our data incorrectly or they interpret the data wrong. And I think that's sort of a question that we've all experienced with putting GIS in the hands of all of us, right? And other people who actually don't know how to use it and make terrible maps that don't say what you want it to say. So that will happen, and we expect that that will happen. But the answer for being able to move forward with an open data solution is that we put a lot of focus on metadata and data dictionaries and technical notes that show that this is what the data are, this is how they can be used, these are limitations of the data. User beware, if you don't read it, too bad on you. If the press comes to us and says, so-and-so misinterpreted your data, I give them all the tools they need. Yes?
So what is your prediction, actually, when the general public will embrace this geomedicine and really try to get some value? Because there's a lot of possibilities.
Yes, there could be.
So what is your prediction? Maybe 5 years, everybody's going to start talking about it? I mean, from your experience, and you probably have gone through all your battle all this. So from your sort of projection, what do you think is the future? Yeah.
Well, I can see some early wins in the U.S. Very quickly with things like providing resources to patients. The example I always like to give is clinicians do a terrible job of counseling about weight management, and yet it's obesity is an epidemic problem in the U.S. So to make the physician's job easier, you can have that obesity diagnosis is in the electronic health record, as is the patient's address. So if you then have the post-visit summary, just printed out a vetted list of resources for them, up to the patient, but now they've got something where they had nothing because the clinician won't spend the time. So those are kind of easy wins, no effort for the clinician, set up the system once, and it works. And then I think that the bigger kind of geomedicine projects are more likely to happen in countries that have a more nationalized system. I'm going to be, hopefully, traveling to Taiwan in October, and they're setting up a number of workshops, and they want to train a lot of people in informatics to do geomedicine, so they're anxious to set up a program. And I think in smaller, less complex places, we might see it, and that would be a great way to jumpstart it in the US, to say, look, they're doing it, and look at return on investment. So I can see sort of a dual track, a little bit slowly with the easier stuff here, and then hopefully some other examples that will make us stand up and take notice. But that's just a prediction. Yes?
Just going back to your point about surveys versus electronic streaming flow, but is the electronic streaming flow uneven around the state? Are there certain communities that have a lot of flow, others that have very little? And doesn't that bias the sample.
Yes, well, at the moment that's absolutely true because not everyone's adopted electronic health records. But that's why, healthcare reform, I think, in all of this is helpful because there is some mandate to get on board. But yes, so you would be, for probably the near future, biasing against those clinics and hospitals that just refuse to adopt because they can't afford it, they don't understand the technology, or they just don't want to get involved. They'd rather retire out and be done with it. So I think it's going to take maybe a generation to get there, but the amount of data still that we can get beforehand will be great, and maybe we can understand where the biases are and then figure out what we can actually say for local areas rather than a generalizable state. Yeah, good point. Oh, yes.
How worried are you about the lack of experience that we have with big data analytics in the context of spurious results and potential political pressure that will supported by totally meaningless spurious results? I mean, like, economists are great at covering those spurious things and saying, well, rainfall is the best correlate for GDP. The totally meaningless correlation coefficient of 0.99. And we only destroy patients that could probably help to destroy life. So how risky do you think is that?
Well, let me answer the first part. I'm actually very worried about our public health and health system infrastructure being capable of doing big data analytics at all. I don't see that a lot of places have that infrastructure yet. It's expensive, and we don't really have yet a cohort of great data scientists, and there's not even job classifications in government for data scientists. So this is a big difficulty. But assuming we get all that, and then we end up with, analytics, maybe, in the early days, you're probably right, I'm guessing it's going to be a mountain of poor results until we figure out how to do this right. Hopefully, we all remain as skeptical as we have been and take results with a grain of salt to try to verify. I heard on NPR last week, and I thought it was really interesting. This editor is creating a journal that only does validation studies. So, he makes the argument that a real problem in our publishing now, because you get to publish positive results once, and anybody trying to repeat the study and publish and validate those results, often won't get their paper accepted because it's already proven. So this editor is taking the approach of, we see validation study after validation study to feel more confident in the results. And I think that goes exactly to your question, that multiple people will be looking at the same issue over and over and see if it is spurious or not. That seems like a good solution, but I only know one person really thinking that way. So yeah, it's a problem, and I think we're just going to have to remain skeptical and find solutions. I don't know. I'm supposed to just give the ideas and get to figure it out.
How do we get our competition?
Yeah. One at a time. Yes, you had a question.
Oh, well, yes, my question is, you said you are going to Taiwan?
Yes.
Okay. My understanding is now in the United States, now we have that kind of concept, geomedicine, and we think it's going to be some global concept. So it can have the global level of the public health and the use. Can you see that just go to the United States and global?
Well, I think that, I have no idea how this is going to play out, but my suspicion is that it will start, like many things do, in a siloed way, that it'll take on here and there. And so maybe, we have a pretty good feeling about Taiwan and they're interested in it. So maybe it'll catch on there. And then it'll catch on, not in the whole United States, but in some hospital. And then it'll catch on somewhere else. But with things like open data, I think that there's a movement toward considering data standardization so that interoperability can happen and we can all federate, statewide, nationally, potentially globally. I mean, we're maybe more than our lifetime away from that. I don't know, things are moving pretty fast, but there's a lot of policy that's got to happen in between. So it's a nice idea. I don't know if it will happen.
So following on that, do you think that like an ISO type of standardization or a grassroots open data is the real future? Is it going to require governmental intervention in order for it to be standardized?
Well, intervention might be a strong word, but leadership might be the word that I would use. You know, for example, I can speak only to my experience, and that is with our open data portal. We know that a number of other states, we're going to be like the 39th or 40th state with an open data portal. So, you know, it's kind of old hat, everybody's done it. But a lot of states, when they did it, they said, okay, we're going to take all our data sets and throw them up online, and we'll worry about metadata and data standards later. Well, California is not doing it that way. And my work has been focused on, let's say, data standards for the state. I've been calling Federal Health and Human Services and talking to them what are federal standards that we all should use, because California is sort of famous for inventing their own standards. And so I'm trying to make sure that we use not only even national standards, but global standards where we can. We're using Dublin Core for our metadata. So, so we're really trying to do that, but I think it's a leadership issue rather than a regulation issue. I just don't see anybody, you know, I mean, not enough people care about metadata anyway, but I don't see it yet becoming a regulation. It'd be nice though, or somebody would say, must do it. Or at least you must do it. Yes.
Do you have any comment about the medical legal implications of this type of data being accessible, either from the standpoint of personal litigation against individual providers, or possibly in a class action fashion against the state for things like they already have identified in China, like cancer villages, things like that? I'm just wondering, as you're discussing policy and how it's evolving, it seems like you've synthesized a lot of comments about politicians and policymakers. It seems like it would be good to build in some legal protections against how this data is expected to be used, because it's already overwhelming for physicians to come through all the available literature. This just seems like another maybe pit of quicksand. Well,
so let me distinguish between like geomedicine and the data that physicians use. I expect that they're using environmental and global population data to inform individual health behind firewalls, and I don't see that as having any privacy breach protections. But in things like an open data portal, which may be consumed by some of these applications, I talked about the mosaicing and all these laws on privacy and policy, and I do think that at least my reading of California law, two things. One, we have a terms of use agreement. Most people don't read those, but we have it, which does say what you can and can't do with the data. And if you manipulate it or you change it in any way, it's no longer Department of Public Health data. So we do talk about that, but also in California law, it is enough to responsibly take every precaution to protect identity. If there's a breach, it can happen. You know, we won't all go to jail. Obviously, it'll be bad news for whoever gets caught, and the media will do what it does. But if we've been responsible in our approach, then we don't get in trouble. So, I mean, take that for what it's worth, because when I say we get in trouble and then I think about what the media storm would be, that might be enough to lose your job.
Actually, I think I asked my question clearly. I was talking about I'm a physician. So I was talking about from a physician's standpoint in terms of, like the example of fluoridated water. That's really, you like to think that every pediatrician practicing in that area would have the same map on the wall and would identify which children need fluoride supplements. It could be an enormous class action lawsuit against all pediatricians in that area, for example, when people realize, oh my gosh, the doctor should have known better. That's what I was talking
or like a lack of knowledge. They're not using the data to inform their practice.
Correct. Should have known better. That kind of thing. That the electronic medical record, as you know, is actually already a little bit troublesome because people believe that we have access to all that information in a way that has never been previously expected. So that's kind of where I meant.
Yeah.
This data's out there, and well, my doctor should have known I live in this area where maybe there's more than I guess,
Yeah.
And so I'm just curious about how that policy is being developed in combination with how data and big data is evolving. That's what I meant.
Yeah, I would say it's not being developed or evolving at all. But so I think that it's got to take hold a little bit more. Or, people have to start doing it before they start thinking about the consequences, which is not necessarily the right order, but that's how it generally happens. So, but that's a really good point. I'm going to start to think more about that.
Well, because lawyers will think of that, and they'll be trained for that before doctors will.
We do have to
most people care big data. The answer is, I'm sure, the Bar Association cares.
Well, you know what happens in court, right? The way that medical legal action will happen in court is that you have experts will say, should they have known this? This is reasonable practice, and And so if it's not sort of taken hold at 50%, you can't say that's standard of care. People aren't all doing it. So so I would say it's going to take a lot of geomedicine to happen before anybody's really going to see problems from that. But hopefully we'll get to thinking about that before we get to that 50% mark. It's an excellent point.
Especially if you're actually making the data publicly available, so even the patients are aware of what's happening. So that's actually another problem that we want to.
Right, it goes back to expectations and how they might interpret the data. Maybe it's different from what you can draw parallels to direct-to-consumer advertising, right, and how that changes patient behaviors and clinician behaviors. One of my colleagues did a study looking at that very thing, where he had standardized patients come in, and so these were actors, and they had 250 different doctors that they went to, and each doctor got 2 standardized visits. They didn't know, they were masked to who these patients were. And they would have 2 different complaints. One was a musculoskeletal kind of ache or pain, and another was a kind of a depressive complaint. And one group of patients would come in and say, "Doc, I've got these symptoms, and how can you help me?" Another group would come in and say, "I think I might need an antidepressant." And another group would say, "I need Effexor." And they found that the group that wanted Effexor got Effexor. And that there was a strong influence on physician behavior. And so I think this would be kind of the same thing. That, maybe that's the grassroots way to get geomedicine happens. Patients demand, "Hey, why are you asking me about my history?" That's what my friend Bill's doing. He tells his doctor all the time, "You need to be asking about where I've been." Yes?
I come from a research background, so what I was thinking that your open data, would it be available only to the physicians, or would it be available to the business, kind of like the businesses that make medicines, so that tomorrow based on the open data, a particular location, a company thinks of making a capsule or medicine which is more which would be more useful to a particular kind of disease. And then some ethical values or lawsuits come on based on that our data was not just open to doctors and physicians, but also to the corporations. So would that be a problem to come into the future?
Well, if I'm understanding your question correctly, open data is going to be open to everybody. And so it's completely for whoever wants to use it. Now, these portals, to be fair, they can be semi-open, right? You can have an open data portal where you share information internally within your organization, and then you have data that you maybe share between sister organizations, and then you have data you share openly with the public. Our intention in public health is that all data is freely shareable to everybody. And so hopefully we wouldn't have those constraints if you're looking for business solutions. Did that answer the question?
No.
You want to rephrase?
I got the answer, but it's just that I'm too scared with the fact that tomorrow any particular business is always open to any kind of ethical lawsuits. So I'm just thinking that how can we prevent such things happening when we use open data instead of just the physician and the patient knowing about the details?
Yeah, well, I want to just be real clear that we're talking about a sense of different things. Open data is one way to release some of this fabulous environmental exposure and population data that can then be consumed by physicians as they're treating patients. But the interaction between physician and patient never leaves that room or that electronic record. Right? So there shouldn't be any legal consequences there, provided that we don't have people who should have known but didn't. So hopefully that wouldn't be a concern. Well, thank you for all the good questions you've given me.
I'll just have small appreciation for you for this one-to-one second talk. This can be used as a weapon. Some people.
That's beautiful. Thank you.
Thank you very much.
Class.
Well, I just wanted to say that while this was our concluding event for this year, I think I can simply say that we saved our best for last. So again, please a round of applause for our Dr. Geraghty was kind enough to give us the go-ahead to video report for talk, and I believe the Q&A session went through so many good questions from all of you as well. If you had a colleague or a friend or an acquaintance or a student who couldn't be here today, We will be uploading this to YouTube, I believe, shortly. And please spread the word around, and so that more people can get value out of this. So with that being said, I think there are still sorts at the back of the room. If you have a chance, please stay back, have a little peace network. Or otherwise, I would like to wish all of you a very relaxing and productive summer. We will have more speaker events, of course, in the fall, and we will be sending out more as we have finalized the program. Thank you so much for being here and supporting the event today, and I will see you very soon.